So I have two topics I would like to try and talk about. The first one is delirium, and the second one is pain, because pain is a major issue in surgery, but pain is a major risk factor for delirium, and people who have delirium have difficulty getting good pain management or good pain relief. So I think that there's a real interaction between pain and delirium. But I want to walk us through some delirium first. But I want to ask you a question. How common do you find delirium in your post-op population?
A lot in the ICU.
Pardon? A lot in the ICU? Okay, and on the med-surg unit as well. Okay. Well, delirium, a brief history of delirium is that when I was a nurse back in the dark ages, it was just called a confused older adult. And it was expected. It was, you were old, you were in the hospital, you got confused, that was just the way business went. And nobody really paid too much attention. And no one really cared, primarily because the people were old, and old people are confused anyway, so they just get more confused when they're in the hospital. Then later on, we started talking about acute brain syndrome. And then only in about the last 10 or 15 years has delirium really become what I would call a hot topic in the healthcare literature. And this has primarily been due to Dr. Anouilh down at Harvard. And she tells the story that she started looking at delirium, but she really became interested in it when her father, who was also a physician, had surgery, had delirium after surgery, and the distress that it caused him, and the distress that it caused her, and the frustration that somehow she could not have prevented this. So she's become a real advocate, and we've now heard a lot more about delirium in the last 10 or 15 years. Delirium, the definition is, and I'm really talking about post-operative delirium, not emergence delirium for those of you who work in the PACU. So I'm talking about what happens post-op day 1 or 2 is usually when delirium starts. And it's a syndrome or group of symptoms. It's not really a disease in and of itself. It's a reflection of a group of other symptoms. Do you see this blue thing at the bottom of your screen? Those of you who are from off-site remote, do you see the full slide?
No.
No. You have this blue presentation thing at the bottom?
No.
They don't see that. Okay, they see the full screen. Okay. So it's manifested first by an acute onset. It's a fluctuating in mental status. It's characterized by inattention, fluctuating levels of consciousness, disorganized thinking, and then either an altered emotional or behavioral status, and it's often seen as hyperactive, hypoactive, or mixed variety of delirium. There's a high variability in the estimates, and many people assume or indicate that it's probably underestimated, because very often what's called delirium, hypoactive delirium, is very often not recognized because the patients tend to be very quiet, somewhat lethargic, and people just assume they're recovering from surgery or not feeling well and don't really think of it as a form of delirium. The prevalence on hospital admission in older adults can be around 20% or somewhat higher. The post-operative delirium incidence ranges from 15% to 67%, partially depending upon the type of surgery. And the IC is up to 80% of older adults experience delirium in the intensive care unit. The consequences, which we really didn't used to pay any attention to, older people were confused, and we never thought about what happens to them after they leave the hospital. is that they have a higher rate of complications and therefore a longer length of stay and therefore greatly increased costs. They have a prolonged recovery, and it can take up to a year before they actually recover their cognitive function to the preoperative status. That's a long time to be somewhat not feeling yourself mentally. Associated with functional impairment, long-term functional impairment, cognitive impairment, institutionalization in older adults who experience delirium is much higher. It can be a cause of death, and also the good news is there can be full recovery. By type of surgery, orthopedic 25 to 65%, cardiac surgery 25 to 67%, cataract surgery is quite low, 4 to 7, general surgery 20 to 33, vascular, and then emergency surgery is 59%. So that's well over the total, the 50% of older adults are at risk for some form of delirium post-operatively. It is common, over 50%. It is frequently unrecognized and unattended. And because it's unrecognized, people assume that the rates may be even higher than what is reported. It is potentially life-threatening. It is always debilitating. And 80% of patients who remember their delirium, and not all of them do, but of those who do, 80% report that it caused severe distress. But if you're talking about an older population with all of the physiologic changes that you just heard about, and their inability to respond physiologically, not counting mentally and emotionally, and they're reporting severe distress, you can already see how that is going to prolong their recovery and cause more debilitation. 76% of families report feeling severe distress when they have family members who are experiencing delirium. And nurses report severe distress trying to care for patients with delirium. And part of that distress is caused due to the frustration of how am I supposed to take care of this person? How can I fix it? And not being able to find any way to fix it. Because there is no specific treatment once delirium occurs. So delirium is predictable. We know that many people get it. We have some risk factors for those at highest risk. It is potentially preventable, but there's no specific treatment once it occurs. Therefore, the primary goal when you're thinking about delirium is prevention, prevention, prevention. Recognition rates are less than 50%, and the reasons for the failure to recognize delirium is very often is that the diagnosis is really based on provider assessment. There's no lab test, there's no MRI, there's no whatever, except for the astute observation of the clinician who's providing care at the bedside. The significance of delirium until just recently has been greatly underappreciated, as I said at the beginning. Very often the diagnosis is not even considered or pursued or paid any attention to. There's inadequate attention to systematic assessment that would help to detect delirium at its earliest stages. So in addition to the prevention, it's early detection as soon as you see a change in behavior. There's also some evidence that provider assumptions and bias, as I indicated earlier, that people are old, therefore, of course, they're confused, and very often delirium is confused with dementia and or depression, and so not thought of as delirium, and therefore it requires different interventions. And there's often a lack of familiarity with assessment tools. What assessment tools are used in your institution? Do you know what assessment, the standardized assessment tools used at all?
We're lacking that here, actually, yes.
Okay, so you're not currently using a standardized. We'll talk a little bit more about that. Hyperactive is the most recognized because we tend to recognize delirium if people are restless, agitated, overreactive to a response, and hyperactive tends to have more severe outcomes. Hypoactive is the most common type of delirium that older adults experience, but it's also the most unrecognized. And the challenge with this is that it's common, it's unrecognized, but they experience many of the same consequences and sequelae of people who have hyperactive delirium. And hypoactive delirium is characterized by reduced psychomotor response. The patient's quiet, they may be lethargic, apathetic, they may be sleepy, they may have withdrawn behavior, all of the behaviors that you might expect to see in an older adult who has had surgery. They're not going to be leaping around the room or demanding attention. They're going to be quiet. They're going to be tired. So you're going to say, well, of course, rather than thinking about delirium. And then there's a mixed form of delirium where people vacillate between hyperactivity and hypoactive behaviors. So the assessment of delirium, some people have called delirium should be the 5th vital sign. Well, a lot of people think that should be pain. So some people are saying the 6th vital sign. But the message is that every time you interact with a patient, there should be an attention to thinking about, is there any evidence that there is the beginning onset of delirium? So it should always be in the back of your mind, whether you're taking the temperature, the blood pressure, going in and administering pain medication, going in and changing a dressing, going in and helping to end whatever interaction you're having with that patient. There should always be, is everything seem to be as it should be, or am I seeing something that says, something isn't quite right here? Do I need to pursue it further? I passed out in your packet the confusion assessment tool, which is the most commonly used assessment tool. Almost all of the research done on delirium is based on the confusion assessment tool. It's not the only one. There certainly are a number of others, but I decided rather than focusing on all the assessment tools, I would just focus on this one. And like many assessment tools, the more training and education there is about the tool, the better the assessments will be by those who use the tool. And very often we distribute tools and say, oh, here's a new tool, go use it in your assessment of patients, read up on how to do it. When, yes, you can do it that way, but the most effective way is to have an in-service or some education, some practice on using the tool in terms of the observations. So the observation tool is really based on acute onset, the presence of inattention, fluctuations in behavior, and then what is the behavior? And then disorganized thinking or altered level of consciousness. If you look at, there actually are some questions, some specific issues that you look at in terms of trying to identify each one of the characteristics. And the tool generally takes between 8 to 10 minutes, which is one of the reasons why very often it isn't used at every interaction. So my advice would be, have this handy tool in your pocket. You see any change in the patient's behavior. The family says, Mom doesn't seem quite right today. Or the patient says, I don't feel quite right. I feel funny, or things are different, or whatever the language is. Then you pull out your handy-dandy confusion assessment tool and say, well, let's just check this out and see what's going on. The scoring for the tool is 1, an acute onset, 2, the presence of inattention, and either the presence of disorganized thinking or an altered level of consciousness. So there's actually three things that have to be present. One, acute onset and fluctuating course. Two, inattention. And then either disorganized thinking or changes in consciousness. If you have those three elements present, then you can suspect that the patient is having an episode of delirium. And the initial response to a suspicion of delirium is a rapid response team. Very often, well, I don't know if it really is or not. Let's wait and see what happens. The delirium continues to increase, gets more severe, and complications increase, and it's a downward spiral from there. So some authors recommend that if this is an acute brain failure, just like an acute myocardial infarction, an acute infection, an acute respiratory whatever, and should be treated with a rapid response team, or at least immediate attention. Here, just you have a handout on this, and it's just indicating some of the changes that happen with delirium: cognitive changes, emotional, behavioral, and sensory. And so it covers a wide range of behaviors. It's non-specific. It's not like this chest pain. Actually, even myocardial infarction, you can have great variability in presenting symptoms. You can have even more with presenting delirium. One of the pathology of delirium is not well understood. No one really knows what happens in delirium, except we know that there's a alteration in neurotransmitters. We know that it's a complex interaction of multiple pathways, and different types of delirium and different levels of delirium may be the result of this change in pathways, or the precipitating cause may cause a different alterations in different pathways. So it's like, what the heck's going on? We don't know. We only see the result of what's going on. But we do know that, and I passed out this handout on cognitive reserve, and I just want to spend a minute that we all have some level of cognitive reserve. And cognitive reserve is made up of two things. One is the size of our brain, or the number of our neurons. So it's sort of the total capacity of our brain cells and neurons, and its size and weight. But that's traditionally called brain reserve. Cognitive reserve is what happens to those brain cells or within those brain cells through life experience, through education, through our basic intelligence, through our ability to adapt, problem solve, cope with situations. And that as we age, we lose some of that cognitive reserve because we lose neurons, or we lose neurotransmitter functions, so that cognition and stimulus responses are slowed down. Surgery decreases that cognitive reserve even further, probably due to some changes in neurotransmitters and oxygenation. And then if you have aging surgery and the person has any degree of dementia prior to surgery, then the cognitive reserve is even less. So you take someone who's normal aging, you've got some loss of cognitive reserve, you put them under stress and the inability to respond to that stress, and you lose even more cognitive reserve immediately post-op. And then you have any degree of dementia, which may not be noticed, and you've got a much smaller. Each of those diminishments in cognitive reserve can result in higher risk of delirium. So what are the risk factors? And the idea is that if you can identify risk factors and the person who's may be more apt to have delirium, maybe you can do some preventive strategies before surgery or during surgery. My take on this is that you assume any older adult, however you want to define older adult, and typically we define it as 65, is at risk for delirium. There's different levels of risk, but almost by aging, due to the inability to respond to stress and the diminished reserve capacities in almost all systems of the body, you can take, I have a neighbor who's 75 years old and he is still winning fencing competitions around the world internationally. But if I put him in surgery, under surgery, he's going to be more at risk for experiencing delirium than you are, or that some other person who's in their 30s or 40s. So you start off saying, this is an older person, therefore I have to be thinking delirium. If they have any of the other predisposing factors, such as any level of cognitive impairment or dementia diagnosis, then that risk increases substantially. Cognitive impairment is a major risk factor for delirium. And very often they recommend doing a mini mental status exam 24 hours before surgery, preoperatively, to determine that risk. Because very often older adults can have subclinical disease processes going on. And you may not see it as you look at the person, but if you do specific testing, you may be able to identify that the person is having some changes. Medical comorbidities, particularly those that result in severe illness, is a major. So as the comorbidities increase, or as the lack of control of those comorbidities increase, the risk for delirium increases. Medications is another major cause of post-operative delirium. Benzodiazepines being a major. And it's amazing how many older adults are prescribed benzodiazepines, even though the literature has said this is a no-no for many, many years. I passed out a handout called, actually I don't think I passed it out, but there is a list of drugs called Beer's List. Any of you heard of Beer's List? Beer was a, okay. Is it posted in your unit?
It's posted.
Beer's physician back in 1991 who created this list of drugs that were bad drugs for older adults that increased risk of complications. Since 1991, there's been a lot of drugs have been added to that list. Most pharmacists, you should check with your pharmacy to see if they have Beer's List in front of them. You should look to see if there is one on your unit. And look at your patient's drug list and see if it's on the list, Beer's List, as an avoid, or as a not recommended, or as a use with caution. Nutrition and dehydration, we've already heard a little bit about the effect that that can have, and therefore it's a risk factor. Impaired functional status, sensory impairment, abnormal lab values, and a couple studies cited a BUN creatinine ratio of greater than 18. All of these are predisposing factors to delirium. Precipitating factors are those events that are happening immediately. So predisposing is before they even have surgery. What is their risk? And then once they had surgery, and either in surgery or immediate post-op, a whole host of things can happen that can precipitate delirium. Medications being the first. Surgical blood loss greater than 800 cc's has been found as a precipitating factor. long or complex surgical procedures where the patient's under anesthesia for a long period of time, or immobile for a long period of time, or under physiologic stress for a long period of time. All sorts of environmental factors, hospitalization itself, noise level, multiple diagnostic procedures. And this is not only due to the distress of the diagnostic procedure, but as you heard earlier, if you dehydrate the person because they're having these multiple procedures, or you're giving them additional medications because they're having these multiple procedures, you're putting them at greater risk for delirium. Staff changes are having a stable staff is one of the greatest ways to prevent delirium. Having somebody that the person knows, providing ongoing, continuous care. Now, in the old days, when you did 8-hour shifts 5 days a week, it was much easier to maintain that continuity of care than today, where we're having 10-hour shifts and 12-hour shifts and part-time per diem people and changes in staff. But it is a major factor both in prevention and in treatment. So all of you who work on post-op units, medical surgical units, this is something that should be discussed. And it should be discussed at an institutional level because deliriums are a major, post-delirium is a major cause of readmission. So it's decreasing costs.
I think we're pretty good at giving the same nurses the same assignments when they're on duty. You know,
right, but then if you've got somebody who's 3 days post-op and you've got 3 different nurses on those 3 different days.
Exactly, that's what it runs into.
And you have 3 different shifts. You know, you're multiplying the number of people who may not know the patient. And the reason for that is you may not know the patient well enough to be able to observe that there's a change in behavior.
You don't recognize the changes.
Hypoxia, fever and infections, abnormal lab values, sleep deprivation, immobility, which is why the feet to the floor is a critical intervention in preventing delirium, and pain relief. So what are some delirium prevention guidelines? You don't have a handout on this because I just came across this the other day. It's a 2013 called an AWOL screening risk tool. So age, spelling the word world backwards, which I can never do anyway, even in my normal cognitive state, because it forces the person to pay attention. And if they're experiencing any inattention, you're going to pick it up fairly quickly. Typical orientation, and then what is the level of illness, mild, moderate, or severe. And this tool needs further testing. It just came out, but I think it's worth kind of keeping in the back of your head with pre-op patients to kind of do a quick look at this just to see if you pick up anything. One of the things is that people who come in with high vulnerability to delirium often require a very low, noxious insult to tip them into delirium. So if you have high vulnerability, it won't take much to tip the scales. If you have a patient who comes in who's not at high risk, it's going to take a higher level of precipitating factors possibly before they will experience delirium. So that's the reason for thinking about if you can identify people at risk early, and then you're aware of the precipitating factors, you know who you're really going to have to watch very, very carefully for that early onset. So prevention at the preoperative, intraoperative, and postoperative stages. There is no single intervention to prevent delirium or to intervene. So the goal is to think about how do you maintain as much physiological integrity as possible. And if you see changes in any one of these corners, in the cognitive adaptive, sensory perceptual, or neuromuscular, change in any one of those is going to cause a change in the other two, and you're going to have a cascading negative situation. So the goal is to catch as immediate a change in any dimension. And we often tend to think, well, you know, when the pain gets 10, or when the oxygen gets such and such a low, or when the lab values do this. No. Start looking immediate time that there's a change in any dimension. So I handed out guidelines for delirium prevention, looking at pre-hospital, before the patient even comes in for surgery. As soon as a person knows that they're having surgery, the pre-op assessment should look at, okay, what can we do to decrease the risk of delirium? Cognitive training, mental activity exercises, puzzles, games, Scrabble. I do my 3 to 4 games of Scrabble every night before I go to bed, just to try and keep me a little on the mentally alert side. Determine if there's any presence of depression or cognitive impairment and treat. Stabilize comorbidities. Review medications. Eliminate any that are not absolutely necessary. And every medication should be evaluated in terms of what is the anticipated benefit, what is the anticipated cost in terms of side effects or potential risks, and do the benefits of this medication outweigh the cost or the potential side effects. And very often, patients are given medications, well, we think this will help, well, we think this will help, well, we think this will make a difference, without really doing that kind of benefit-cost analysis. Maximize their mobility and exercise, as was mentioned earlier, hydration, nutrition, get them into a stress management practice relaxation plan, and discuss with the patient as part of the pre-education what are the potential for unusuals after surgery, so that the patient and the family is well aware. If there's any change, let us know. Don't wait until there's a big change before you inform something's going on. Give the staff a clue as soon as possible. Once admission to the hospital, but before surgery, and this doesn't happen very often, but when it does, maintain patients' active involvement. Keep them going. Keep them alert. Keep them involved. Keep them engaged. Orient to the environment. Full orientation to the environment. Initiate all of the protocols: nutrition, hydration, sleep, pain relief, sensory, use of sensory devices, noise reduction, elimination. Every single one of those care protocols should be implemented the minute the patient comes into the hospital. Limit procedures or limit how they're scheduled. Evaluate laboratory values from day one so you know what they are, so you're very quick to see if there's any change in them. And there is inconclusive evidence, but some evidence to suggest that preoperative Haldol in patients at risk for delirium, that it doesn't prevent the delirium, but it decreases the severity of the delirium. So again, it's not yet recommended, it's not yet a guideline, but it is this may help.
Now, would this be immediate pre-op period, or something that we would do a few days before they are admitted to the hospital?
A few days before they come in. Interoperative, go ahead.
That amazes me, because I worked in long-term care, and Haldol is the taboo drug of choice in elderly.
Right, and the only time it's used in patients with delirium is if it's a safety concern, if they really are at risk for hurting themselves or somebody else, then that's the only time Haldol is used. A few studies have shown that preoperatively it may help. My recommendation would be wait until there's better evidence, unless you've got somebody who's really at very high risk. Then it may be worth doing. But if you don't have someone who's on that with dementia or high risk scale, but keep open to the literature about this and look for further evidence. Intraoperative prevention, for those of you who are in the OR, careful orientation to the environment and taking time. Letting the older person get settled in the environment. Perioperative warming blanket from the beginning, not waiting until post-op, but right from the beginning. There's some suggestion, which I don't think this will happen. What is the ambient air temperature in most ORs?
68 to 72 degrees.
Here it's like 64.
Yeah, it's down around 62 to 64. The real recommendation is 70 degrees. I put it at 68 because I never thought I'd get anybody to 70. So I thought, well, if we say 68, it may help.
It's really cold here.
But there is some evidence that that warming really does help prevent post-op delirium. Minimize medications, blood loss, and fluid loss. And I say ensure pain relief. And you say, well, the person's under anesthesia. Why do we have to worry about pain relief? And there's some evidence that you will see physiologic responses, even in older adults, to the experience of pain, and to try and minimize that pain response. Having a caring present, continuing to talk to the person during surgery, continuing to use touch during surgery, continuing to use sort of a reassuring kind of language. I'm here, everything's okay, we're moving along, we expect to be this long, things are going. And does it work? Who knows? But it certainly doesn't do any harm. And there's some evidence that certainly a calm OR environment improves outcomes. There really is evidence of that. So trying to keep that OR as stress-free as possible, because the client may experience some of that stress in the OR and respond. Post-operative, and I'll just mention here also that in the intraoperative, positioning and making sure the patient is physically comfortable to relieve some of that pain as well. Post-operative prevention, and this is where the biggest concern is, because very often many of the noxious insults can occur after surgery, so trying to keep those noxious insults as minimal as possible. Again, orientation. What's going on? What's going to happen? One, who's who, who's what, minimizing the number of people in and out of the room, the amount of noise, the amount of chaos. And very often we talk about quiet environments, but we can't have an absolutely quiet environment, because there has been research that shows that older adults who are in private rooms, who are not ambulatory, actually can experience delirium. So you have to find that fine edge between enough stimulation but not too much stimulation. And that has to be an individualized characteristic, because each of us responds differently to what do we need to ensure that we stay on our toes but are not overwhelmed. Systematic cognitive assessment. Questions? Systematic cognitive assessment.
She did.
Oh, you did have it. Okay.
Hey. Hi.
Yes, I got you.
Hi, I'm Doreen. I'm from ADH, and I have a question regarding your slide on delirium rates with respect to type of surgery. And I want to know if most of the research data that was gathered for these procedures were any of these patients outpatient. Obviously, the orthopedic and the cabbages were inpatients, but like cataract surgeries, day surgery, general surgeries are day surgeries, so is this all of this research in hospital, or is some of it also out of hospital? And the reason I ask is because I'm concerned with discharge instructions for family members, for their loved ones, if this type of delirium occurs at home.
Great question. Great question. Most of the work on delirium has been done in hospitals. There is some evidence that outpatient surgery, there is less delirium, and that may be because of the type of person who has outpatient surgery. But that there's also strong recommendations that family be informed about the possibility of changes in behavior and the onset of delirium so that they can get immediate attention. So it actually should be part of, if you've got a patient who you think is at risk, and my belief is that anyone over 65 is potentially at risk, but if you have someone who's at even, definitely anyone who's at moderate risk should definitely be informed about the potential for delirium. So you may want to add that to your discharge instruction as an as-needed thing, or even discuss it with everybody.
Thank you.
Does that help?
Yes.
Okay, great question. And then a systematic cognitive assessment should be, as I said at the very beginning, where you kind of every interaction you're just looking for any changes in behavior, and you listen to family members. And very often I've heard providers say, well, they probably were confused at home, or they probably had this at home, and the family just didn't notice because they were around all the time, so they didn't notice it, but now that they're here, they do. That may be true, and I'm not saying that that's not certainly a possible situation, but I would put that as my last response and not as my first response. I would check out everything else first to make sure. Minimize invasive procedures. Catheters has been found to be, again, catheters has been highly associated with delirium. Is it because of the catheters themselves and the irritation and discomfort that they cause, or is it the reason the person has the catheter that's the precipitating event? But whatever it is, get rid of all tubings and devices as soon as possible. Maintain all the preoperative protocols. When I talk about prevention or intervention with delirium, I go back to basic nursing 101. Comfort care, astute observation, and making the patient as comfortable as possible seem to be the bottom line of, if you were to take all of the individual preventions and interventions and say, what are we talking about? It's not medicine, it's nursing care. So maintaining all the protocols around sleep, noise, hydration, nutrition, elimination, immobilization, a strict or rigid pain relief protocol, decreasing risk of infection, ongoing family and patient teaching about unusuals in terms of behavior, and excessive monitoring of medications to don't start any unless it's absolutely necessary, and stop as soon as possible. And anytime a medication is ordered post-operatively, check it against the Beers list and weigh the benefits and the costs. And then home and post-discharge prevention, ongoing patient and family monitoring, discuss the potential for delirium, ongoing pain relief after discharge, maintenance of hydration in older adults in the home environment as well as in the hospital environment is very difficult to achieve because of the diminished thirst response. They don't ask for water, and if encouraged to drink it, I'm not thirsty. I don't feel. So there has to be some real negotiation and real education of the family for reinforcement with the patient why hydration is so important. A good sleep protocol, maintenance to elimination, and provider follow-up, and providing contact information if the family has any questions. I mean, these are all basic nursing actions. There's no real high-level science. It's everything that we know and very often feel that we don't have the time to do. In terms of prevention, identifying the individual risk factors so that with each person you go back and you say, okay, what are the risk factors, predisposing risk factors that's going to increase the risk, and then target some preventative strategies to those specific risk factors as well as the general risk factors. In terms of intervention, we talked about identifying what some of the precipitating events are. Very often we will find a precipitating event and think, that's it. Okay, I found what caused it, dehydration. We get some fluid into this person, it'll be just fine. No. If you've got one, you may have others. So it's important to go through a systematic assessment to see, in addition to the one that you found, is there a potential there might be others, or you may have found that one for now and treated, but another one may emerge. Communication. Patients who experience delirium talk about that one of the things that was most helpful for them when they were experiencing delirium was having someone talk to them about their experience, reassure them about the experience, what was going on, why was it happening, what we're doing to take care of it, and that what you're telling us about your experience, the hallucinations, the illusions, the voices, the whatever it is, are real to the person, but that they're safe, they're secure, and you're taking care of them. And that this kind of language and this kind of communication was very important when people were experiencing delirium. And pharmacologic interventions are usually not indicated to treat delirium. In fact, medications can make it worse. So don't go having providers start throwing all these medications around. Post-discharge, I think we've talked about that enough. Some of the statistics are a little shocking in terms of the effect of delirium. Okay? So pain, we just said it increases risk of delirium. One of the major issues with excessive surgical pain is that it can lead to chronic or persistent pain after discharge in 50% of patients, and that 80% of same-day surgery-related pain is undertreated. And this is very often because when they go home, there's not a good pain protocol put in place for the patient. Age-related changes in terms of pain cessation and perception. There are changes in the number of the sensory neurons so that pain may not be felt as immediate as it is in younger people. There's alteration in the speed at which that pain sensation is transmitted to the central nervous system. There's demyelization of the nerve fibers, again interrupting transmission. The number and size of CNS neurons that slows pain sensation. There's a decrease in the opioid receptors in the central nervous system that reduces the ability of the body to respond to the natural opioids produced in the body. The body cannot respond to those as well. A very important point in terms of thinking about pain in older adults is that the pain signal is transmitted more slowly and interpreted more slowly. Therefore, the extent of the injury is greater before you get a response. So you can have much more tissue damage, a greater degree of infection, a greater degree of inflammation before the older adult may report that there's been a pain response. So it's important to realize that they may be sicker when they start talking about pain. So you need to really pay attention to that. When you hear pain from an older adult, it needs to be immediately attended to in terms of cause. Preoperative causes of pain. 70% of older adults have chronic or persistent pain preoperatively. They may also have acute pain from the causative injury. Intraoperative causes of pain, surgical trauma, anesthesia. Positioning is a major cause of postoperative pain because of all of the things that were talked about in the earlier presentation on physiological changes. Causes of postoperative pain, surgical trauma, surgical positioning, catheters, IVs, NG tubes, turning, coughing, and deep breathing, ambulating, and the presence of any preoperative pain. And very often we think about the acute postoperative pain and understand that, but don't think to assess the patient of what was the preoperative pain, did they have preoperative pain, what was the cause, how was it being treated at home, was it being treated at home effectively, and how can we continue that effective treatment while the patient is still in the hospital. Factors contributing to inadequate pain relief are the attitude of the older adult, the attitude of the providers. People with chronic pain often talk about the lack of respect that chronic pain gets in the provider community, and very often providers who are caring for someone with chronic pain actually distrust the patient's report of pain. And the patients come to distrust the providers, so it becomes a downward spiral.
Excuse me.
Yes.
I think also we get mixed messages from the literature in science out there, because now the big thing that I'm reading is about over-medication and how the utilization of certain pain medications has skyrocketed.
Right.
And I think that scares a lot of providers into
Not
adequately
Right.
treating pain.
And the flip side of that is very often patients become used to pain medication, which makes pain
So they have
management
tolerance.
afterwards
Mm-hmm.
even harder.
Yeah.
Cultural norms is a huge issue in terms of assessing pain and then treating pain. And I think it's important very often as providers to think about the patient may have ways of managing their pain. And it's very helpful if we ask them, how do you manage your pain? And see how we can incorporate that into the system. The challenges with patients with delirium, as I mentioned earlier, is inadequate pain relief causes delirium, and then patients who have delirium have difficulty explaining their pain, talking about their level of pain, and so you get a spiral situation. There's also been some evidence that shows that patients who've had inadequate pain relief, that patient satisfaction does not correlate well with the level of pain relief that they received. That they almost always will say it was fine, it was fine. so it's not a good indicator. Assessment tools, what do you use for assessment tools for pain assessment in your institutions?
Use smiley faces, right?
1 through 10 smile faces. We also use the FLAC for the nonverbal.
Okay, so you use a variety depending upon the patient's situation. Okay, great. Any others used in any other places? Pain assessment tools? Very often, particularly with the numerical rating system, is that using it for pre-assessment and post-assessment, particularly with older adults, they can have difficulty using a Likert scale. So using some other form, trying to validate the information by using an alternate form as well. And trying to use it, like if a patient gives you a 7 before and a 5 after, you may assume that there's some relationship between those numbers. There may not be. It may be that they're just giving you a number. So doing a follow-up, like is it a little bit better? Is it a little bit worse? Is it a lot worse? So doing some verbal assessment as well as using the pain scale. If you find one that works for the patient, find it preoperatively and use it. If you find one post-operatively, use the same scale so that you have some consistency and know that the patient knows how to use it, can use it. And if a patient says they're not experiencing pain, at rest, ask them to move and find out if they're having pain on movement, because they may not experience it while they're lying there, but the minute they start moving around, it's, oh, yes, dear, I do indeed. So some guiding principles for people who have delirium: try to get a self-report beyond a number. Identify what might, if a person's 3 hours post-op, and they haven't had any pain medication, the chances are they're having some degree of pain. So if they have an overwhelming inflammation, they're probably having some. So if you can identify what might be causing pain, and you have a patient who's delirious who's saying, I'm not having any pain, you may want to do a pain medication trial to see if their behavior changes. Observe for any behaviors. How do I go back?
Just hit the up button.
Right. Solicit support from surrogate reporters, and then conduct an analgesic trial if unsure. Give them some pain medication and see if the situation improves. See if you can get better cooperation, see if the delirium decreases, see if the body language changes, because it doesn't do any harm to do an analgesic trial. And if it doesn't work, then you know there's something else going on and pursue it. Preoperative, educate patients about pain and pain management and myths about pain. They're going to have pain post-operatively. Ask how they treat it. Ask how they would like it treated. Ask what level of pain they typically experience. Talk about the importance of reporting their pain and having it treated. Older adults are less apt to report pain even if they're experiencing it. I don't want to be a bother. The nurses are busy. I should be able to withstand this pain. I should be, whatever the cultural messages are around aging and pain. So talk about why is it important to report it and why it needs to be treated. Find out about presence and treatment of chronic pain condition, determine effectiveness, and also engage in PCA training. Have that down pat as part of the preoperative teaching. So you only need to renew it and reinforce it post-operatively, and you're not starting from ground zero. So all of these should be part of the preoperative teaching around pain relief. Post-operative, managing chronic pain, maintain the preoperative pain management strategy, individualize pain relief plan. One size does not fit all, and opioids are not always the first or best choice. And so with older adults, again, particularly because of the side effect of medications, go low, stay low and go slow. That's it. Stay low. So start with the lowest possible dose, evaluate its effectiveness, and increase with minimal doses over time until you get to the level of pain relief needed. If you start low, look at as many non-pharmacological pain relief methods as possible to try and manage it. Don't just assume medication is the only intervention. Use as many interventions, multimodal pain interventions.
We have a nice cadre of retired nurses who come in and do aromatherapy, music therapy, and we use them quite a
Warm
bit.
blankets, distraction, heat, cold, whatever it takes, everything. Do it all. And the goal is to keep the medication as low as possible and the comfort level as high as possible. Range of motion exercises can be a great benefit in terms of pain relief, both as a distraction and just in terms of getting circulation going and blood flowing. So very often we think about positioning, changing position, but we don't think about actual range of motion exercises as an effective intervention. Documentation of what works. I tried this and it worked, so that the next person doesn't have to start from ground zero. So effective documentation of pain relief strategies. Pain relief modeled after rapid response, immediate, focused, and effective. PCAs work very well with older adults. They say opioids begin at 25. It says, the literature says 25 to 50. Most often 25%. No IM or sub-Q pain medications. Demerol is a huge no-no. I think it's taken out of most pharmacies for pain by now, but perhaps not all. Get on oral as soon as possible. Use preemptively. If you know there's going to be something, turn, cough, deep breathe, a procedure, ambulation, getting to the bathroom, whatever it is, preemptive use. Observe for side effects or prevent known side effects. And acetaminophen and non-steroidal medications can be very effective. They can be alternated to decrease side effects. They can be used for breakthrough. To use those alternate medications rather than depending only on opioids can be highly effective. Non-pharmacologic, non-steroidal creams, I just want to say something about them, particularly for patients who have musculoskeletal pain. My husband has fairly severe rheumatoid arthritis. He swears by Bengay. I'm ready to buy stock in whoever makes Bengay because he uses it by the ton. Doesn't seem to cause any severe side effects if he's not wrapped up in it. But there are some non-steroidal creams out that patients have said are very effective. The only caution is they do get absorbed and they can cause systemic side effects. So you kind of need to keep that in the back of your mind so patients don't slather themselves from head to toe with the non-steroidal creams. Post-discharge, very often with early discharges today that we have, patients will go home, particularly older adults with pain relief, having extensive conversations with the care provider in the home around pain relief. Both the safety issues related to pain relief as well as the effective issues with pain relief listening to the patient. Pain is what the patient says it is. And the use of non-pharmacologic, because very often families will reach for the pills first and not think about non-pharmacologic interventions. Okay, so what's the bottom line? Prevention, astute observation, patient and family education, and active listening and communication. And that delirium and pain management is really around basic nursing care and comfort. It's not magic, it's paying attention to the details. So astute observation and attention. Okay, any questions? I've been having my back to the room here. Any questions from Berlin or Upper Connecticut Valley? Comments? Anything useful?
Great information.
Thank you. So I hope that we may have reinforced some of your previous knowledge, provided perhaps a few new insights or perspectives or way of thinking about surgical care of the older adult, and the returning to some of the very basic things that we've known in nursing for a very long time are effective. And I love Dr. Fetzer's comment about F to F, feet to the floor. I think ambulation is something that we have forgotten about how critical it is in terms of the post-op care of our patients. So, thank you very much.
Thank you.
Thank you.